How about you, Ashley? Have you used both DTPA and MAG3, or
I believe MAG3.
just MAG3? Okay. They both are quite different renal imaging agents, and as you know, the DTPA is mainly used for glomerular filtration, and MAG3 is used for tubular secretion. Okay, do you all understand? When you guys had your anatomy and physiology, let's talk a little bit about the kidneys and what they do, and then we can kind of compare the different imaging agents and go over some protocols.
Yeah, real quick. You said DTPA was used for 2 reasons.
Okay, we do it for arenogram. We also do it for the glomerular filtration.
Oh, the GFR.
Yeah, the GFR. Yeah, it's specifically good for that. Okay, so again, what we're going to be talking about, and when you are preparing your workup for your patient, it's a good idea that you have the urinalysis, yeah. Okay, what we're concerned with in the urinalysis are things like the BUN, creatinine. Both of those give us a pretty good idea of renal function. We're also interested if there's any cells present in the urine. Now, normally you will have a couple of red blood cells. You may have a couple of white blood cells. That's normal. You may have.
Do you look at the urea too, or?
Not usually in the urine, no, because that's blood urea, the BUN. But yeah, when we're analyzing, you know, you may have like some bilirubin in it, because remember, if there is an excessive amount of bilirubin, then it's filtered out through the kidneys. But what we're concerned with here is if we have like white blood cells present in the urine, then that's usually indicative of a urinary tract infection. And it could be pyelonephritis, you know, or cystitis, anything that's doing in there. The other thing that we look for are protein. And protein is usually, you know, protein doesn't go through the filtrate. If it winds up in the glomerulus and in the collecting system, it forms these, like, what we call casts. If you take protein and you put it in a, like a form, and it hardens, then that will go through the tubule and wind up in your bladder, and we call those casts. You heard of that before?
They take the shape of like the collecting ducts and whatnot, right?
Yeah, they take the shape of the collecting ducts. So that indicates that there's been damage to the kidney. So usually either, you know, from an infection or from exposure to some type of toxic agent. And so, you know, it's important to know what's in there so that you have a better idea of what type of exam you should be doing on patients. I mean, obviously, if we're interested in function, then we want to use either the MAG3 or the DTPA. Okay. So we're going to talk a little bit about this, though. The urine formation, notice we have glomerular filtration, and then tubular resorption. Okay. And then the other thing the kidneys are designed to do is water conservation. This is a very important part of our knowledge, because if a patient is dehydrated, what effect do you think that will have on your study?
Filtration rate will be slower.
Lower? Okay, let's say that Mr. Radke comes in, I've been really sick and nauseated and vomiting, and I can't hold anything in my stomach, and so I come into the hospital, and, you know, so they schedule me for a renal study. What's going to happen is it's going to look like I have a bilateral obstruction, because the kidneys will not excrete any water. Okay? What hormone is responsible for the kidneys not excreting any water? Okay, antidiuretic hormone. So the pituitary gland senses that you're dehydrated, so, and remember that ADH acts on what part of the kidney?
That's glomerular.
Well, remember you've got the glomerulus, you've got the proximal tubules, and the distal. So it acts on the distal tubules. It tells them to retain water, and so that's why you get the impression that nothing is being filtered out. We have the same problem in radiology when we give contrast media, because we don't want the contrast media to stay in the patient. It's very toxic. So we want to make sure that they're well hydrated. And that's another thing with you. If you have a patient who's dehydrated, you need to make sure that they have an IV there and they've been getting fluids.
So if they are dehydrated, they'll have a low GFR or high?
Well, what'll happen, they'll have probably any GFR. Because what'll happen is nothing will get excreted. And the radiopharmaceutical will just keep collecting in the kidney, and you'll just see the renogram curves. I've got some examples of it here, so. Okay. So, moving along, okay, I put in here where the kidneys are located. They're normally located between T12 and L3. However, kidneys can go all over the place. They're normally posterior, which means that when you're positioning for a renogram, you have to make sure the patient is supine and that you have the camera underneath them. When would you have the camera anterior?
Transplant.
Okay, when you're doing a transplant patient.